Well, thank you very much. I'd like to thank ASE for the opportunity to speak this afternoon. And what I'd like to do over the next two lectures in this session will be in our first lecture to discuss a systematic approach to imaging a patient with congenital heart disease. And then we'll go through some simple congenital heart disease cases thereafter to sort of illustrate some of this approach. In my second lecture, we'll discuss some more complex congenital heart lesions and how we image those and how our imaging helps in patient management. So let's get going with our first talk here and talk about a congenital echocardiologist is one who presumes that every vein, artery, chamber, or valve is abnormal until it is shown on our echocardiogram to be normal. We will use an organized method to examine the cardiovascular system in a step-by-step approach to avoid missing any extra abnormalities that may be present. We define this as a segmental approach to congenital heart disease, which is really a detailed sequential description of cardiovascular anatomy, including cardiac position and axis, including the apex orientation, the determination of sidedness or situs, including the abdominal viscera, as well as the atrial spatial arrangements. And then we look at anatomy and function of each cardiovascular segment and the connections between those segments through the cardiovascular anatomy. We'll begin looking at position and cardiac axis, and why do we become concerned about the difference between those two? Well, cardiac position looks at where the heart is located within the thorax. The heart can be normally positioned on the left side of the thorax. It may be positioned in the midline, or it may be positioned on the right side of the heart. If it's on the left side, that is levo position. It's on the right side, that's dextro position. And if it's positioned in the midline, we call that meso position. Contrast to the cardiac axis, which looks at the base apex orientation of the heart. So in this example, the base apex orientation is to the left, so we would call that levocardia. In this example to the right here, the base apex orientation or the axis is to the right, so that would be dextrocardia. And here in the middle, the base apex axis is in the midline, and we call that mesocardia. Here's a nice example from the subcostal imaging plane of levocardia. Contrast that with the base apex axis here in a baby that has dextrocardia. Well, why distinguish between position and axis? Well, cardiac position can change depending on if there's any extrinsic structure within the chest cavity. So if you have an extrinsic structure that's pushing the heart to the left, you can have leftward displacement of the heart, but the base apex orientation of that still remains in levocardia. Similarly, if you have a space occupying lesion or pneumothorax in the left thorax, you can push that heart over to the right chest. So you have a dextral position, but you still have levocardia. So the position of the heart can change. That base apex orientation or axis will remain the same. Now, the next thing we need to consider is the sidedness of both of the abdominal viscera as well as the atria. So when we look at the abdomen, the normal situs is with a liver to the right side of the abdomen, a spleen to the left side of the abdomen, and the cecum of the bowel to the right side of the abdomen as well. If we have mirror image or situs inversus of the abdominal viscera, we'll have a liver to the left side, a spleen to the right side, and the cecum of the bowel over to the left side. We can have right atrial or left atrial isomerism, where you might have situs ambiguous with a liver that's on both the right and the left side with an absence of the spleen, or you may have polysplenia, where you have numerous spleens located in a variety of positions throughout the abdomen, and the typical position of the liver is on the left side. Not only do the abdominal viscera have sidedness, but also within the chest cavity, there's situs of the tracheobronchial tree, as well as the lobation of the right and left lobes of the lung. We also need to focus our attention on the systemic veins, including the inferior vena cava, the azygos vein, the hepatic veins, the superior vena cava, and the coronary sinus. As we look at normal situs, we can see the normal position of the aorta. Here is the spine. Here's the normal position of the aorta on the left side of the spine and posterior. Here's the normal position of the IVC anterior to the aorta and on the right side. Patients that have situs inversus, that aorta is now positioned on the right side, the IVC is positioned on the left side, still that posterior position of the aorta relative to the anterior inferior vena cava. In patients with right atrial isomerism, we'll see the aorta and the IVC either on the right side or on the left side, but the same relationship of the aorta to the IVC is present with the aorta posterior to the inferior vena cava. Patients that have left atrial isomerism often have interruption of the inferior vena cava. The aorta tends to be positioned in the midline, and the azygos vein decompresses that area of interruption of the inferior vena cava and provides that blood flow up to the superior vena cava. So whenever you see a venous structure posterior to the aorta, always think about the azygos vein and always think about interruption of the inferior vena cava. Here we can see in these still echo images, here's the position of the aorta in situs solicis, posterior to the inferior vena cava, and with situs inversus, that aorta is now on the right side, the inferior vena cava is on the left side, but still that same posterior anterior relationship of those two structures. Always remember that the inferior vena cava will always drain into the morphologic right atrium. So if the inferior vena cava is present, that is the most prominent hallmark of the morphologic right atrium. And if the IVC is interrupted, most commonly in the intrahepatic portion, the azygos vein will have continuation to the superior vena cava. As we move into the atrial morphology, what distinguishes a right atrium from that of a left atrium? Well, the right atrium has prominent pectinate muscles present, has a broad atrial appendage, has a thick limbus of the atrial septum, as you can see here. The coronary sinus empties into the right atrium and is one of the more prominent features of the right atrium as well as that suprahepatic portion of the IVC, which we said is the most significant hallmark of the morphologic right atrium. Contrast that with the left atrium with the smooth atrial wall that we see within the left atrium, the finger-like left atrial appendage that's demonstrated here, and the thin valve of the fossa ovalis, which is a left atrial structure. As we move to the ventricles, how do we determine what's the right ventricle from what is the left ventricle? Not always as easy in this example pictured here. So looking at the atrioventricular connection and the internal cardiac crux of the heart is the most important way to distinguish the difference between the right and the left ventricle. The tricuspid valve is always inserted lower in the cardiac crux than that of the mitral valve. Here we see the mitral valve inserted into the cardiac crux. Here, inferior to that, we see the insertion of the tricuspid valve. The tricuspid valve always empties into the right ventricle. The mitral valve always empties into the left ventricle. So in this example, this is a tricuspid valve. It empties into a morphologic right ventricle. This is a mitral valve inserted higher at the cardiac crux, and it empties into a morphologic left ventricle. Again, always focus on the cardiac crux. Right ventricle, left ventricle. Well, what about this example? We can look at the crux of the heart here, and we see this valve is inserted higher in the cardiac crux. So this is the morphologic mitral valve, which will empty into a morphologic left ventricle. This is more inferiorly inserted. So this will be the tricuspid valve, and it will open into a morphologic right ventricle. Well, what are some additional markers that distinguish the right ventricle from the anatomic left ventricle? Well, the tricuspid valve has attachments to the ventricular septum, in the morphologic right ventricle. Also, there's the presence of a moderator band within the right ventricle, as well as multiple small papillary muscles. The left ventricle is distinguished in that the mitral valve has no septal attachments to the ventricular septum, has a relatively smooth endocardial surface, and it typically will have two large, distinct papillary muscles. Well, what about the connection of the atria to the ventricles? When you have a biventricular circulation, the concordant connection is a right atrium with a tricuspid valve to a right ventricle. Similarly, we have a left atrium with a mitral valve to a left ventricle. The connections are discordant if we have a right atrium connecting to a left ventricle and a left atrium connecting to a right ventricle. Well, what about a univentricular type of connection? Well, there are three different types of connections that we need to consider: the double inlet, the single inlet, and a common inlet. Patients that have double inlet left ventricle have both atrioventricular valves empty into a common left ventricular chamber. Patients with tricuspid atresia have absence of the right AV valve and have only one AV valve, that left AV valve, connected to the left ventricular chamber. And patients that have a common AV valve or a common inlet ventricle have a single common valve that both the atria connect to a common ventricular chamber. Well, how do we determine ventricular morphology if you have only one univentricular AV connection? We can't use the internal crux because we don't have the offset of two atrioventricular valves. It becomes challenging to use myocardial trabeculations because as we age, even patients with left ventricular morphology may have some prominent myocardial trabeculations. The papillary muscle anatomy can be quite helpful because a anatomic mitral valve will have no connections to the ventricular septum, while an anatomic tricuspid valve will have connections to the ventricular septum. So that may be one hallmark, but the most reliable hallmark to determine ventricular morphology is actually the position of the hypoplastic ventricular remnant chamber when we look at these examples. So when we look at this example here, we see the remnant chamber here located anteriorly. So the larger chamber back here is going to be a morphologic left ventricle. So left ventricles are posterior, right ventricles are anterior. So if the remnant chamber anteriorly will be a right ventricle, then the dominant ventricular chamber will be a left ventricle. Converse that with if the remnant chamber is a posterior chamber, this is going to be a remnant left ventricular chamber, and the dominant ventricular chamber is going to be a right ventricular morphology. So always remember, the position of the hypoplastic ventricular remnant is going to be the most reliable indicator of the ventricular morphology, with left ventricles being in a posterior position, morphologic right ventricles being in an anterior position. Finally, we need to look at how the ventricle connects to the great arteries. In a concordant connection, we have the right ventricle connecting to a pulmonary artery. We have the left ventricle connecting to an aorta. In a discordant connection, we'll have the right ventricle connecting to an aorta. The left ventricle will connect to a pulmonary artery. When we look at a double outlet ventricle, that means that both great arteries are more than 50% committed to one of the ventricular chambers. In this example, this would be double outlet right ventricle because the aorta as well as the pulmonary trunk are both more than 50% committed to the right ventricular chamber. You can also have a single outlet where both ventricles empty into a single great artery, in this instance, an aorta, such as in pulmonary atresia. And then finally, you can have a common outlet where both the right and left ventricles empty into a vessel that gives rise to both the aorta and the pulmonary trunk. This is an example of truncus arteriosus. So as we evaluate patients with congenital heart disease, it's very important to use the segmental approach looking at the CV segments as well as the connections, starting with the great veins to the veno-atrial connection, to the atria, to our atrioventricular connection, to the ventricles, and finally the ventricular arterial connection with its connection to the great arteries. With that, we certainly appreciate our congenital heart disease anatomy much more, and we're much less likely to miss any associated abnormalities of the cardiovascular anatomy when we do this systematic approach. So with that behind us, what I'd like to do for the remainder of this lecture is look at some simple congenital heart disease cases, look at some of the hallmark anatomy that we see in that. And as I said in the next lecture, as we go over cases, we'll look at more complex congenital heart disease. So our first case that we'll look at is an 8-year-old with a history of a cardiac murmur. So here we see a parasternal long axis imaging plane. Here's the left atrium, the mitral valve, the left ventricle, the left ventricular outflow tract, and the aortic valve. And by color flow Doppler, we see a hole here with a significant left to right shunt indicating the presence of a ventricular septal defect. From the parasternal short axis imaging plane, we see the aorta and the pulmonary artery here, and we see the location of this ventricular septal defect at about the 10 to 11 o'clock position here around the aorta. This is the region of the membranous septum. So this would be a membranous ventricular septal defect. You can see that it's adjacent to the tricuspid valve here, as well as a bit distant to the pulmonary valve over here. But this is a classic example of a membranous ventricular septal defect. We can also use the velocity in the ventricular septal defect to predict the left ventricle to right ventricular pressure gradient, and in essence, estimate right ventricular systolic pressure. And in this example, the VSD velocity was 5.2 meters per second. We can use the simplified Bernoulli equation, 4 times the VSD velocity squared. And in this patient, the gradient between the LV and the RV is 108 millimeters of mercury. As we look at the apical view, we can look at the left ventricular outflow tract. We see a dropout in our 2D imaging in the region of the membranous septum, and by color, we see a significant left to right shunt across this region into the right ventricle. So this is a membranous ventricular septal defect, which is the most common type of VSD. It's located in the area of the fibrous continuity between the tricuspid valve and the aortic valve, usually in the region of the right and non-coronary cusps, as well as the septal leaflet of the tricuspid valve, which we saw in our example. It can spontaneously close in about 25% of cases, and it does that by having accessory tricuspid valve tissue that sort of plasters itself over the ventricular septal defect. When that happens, and you see that on an echocardiogram, we call that a membranous septal aneurysm. That's simply accessory tricuspid valve tissue that has either nearly completely or completely closed the ventricular level shunt. So when we look at the anatomy and nomenclature of VSDs, the most common ones are either the muscular defects here in the trabecular muscular septum, or the membranous ventricular septum here, or membranous VSDs. You can have an outlet VSD adjacent to the pulmonary valve as well as to the aortic valve, and you can see there's quite a bit of difference in terminology that one can use for an outlet defect. Can also be known as a supracystal, an infundibular defect, a conal defect, a doubly committed defect. So I guess we in congenital heart disease need to get our act together to come up with a single term for this, but when you read the literature, you'll see any one of a number of terms for this particular ventricular septal defect. We can have an inlet VSD, most typically located in this region here, also known as an AV canal type defect. And then in our next lecture, we'll talk about some of the malalignment ventricular septal defects that when you malalign the VSD anteriorly, you create what's called tetralogy of Fallot. If you malalign the infundibular septum posteriorly, you create significant left ventricular outflow tract obstruction, as well as the potential for coarctation or interruption of the aortic arch. When we look at ventricular septal defects, What do we want to see by echocardiography? We want to see the location of the defect, the size of the defect, the involvement of any other adjacent structures. Are there associated anomalies with the VSD? What is the size of the left ventricle and the left atrium? Because those are the two chambers that really will dilate from the left to right shunt of a VSD. And as we showed in our example, we can estimate RV systolic pressure by looking at the pressure difference between the left ventricle and the right ventricle utilizing the VSD velocity. From an echocardiographic imaging perspective, this is a nice figure to help you in locating different ventricular septal defects. Because the ventricular septum is spiral in orientation, you can never see all the different kinds of VSDs in the same imaging plane. So when we look at the peristernal long axis view, this area here, we can see the perimembranous or outlet VSDs. You can see muscular defects in this region of the ventricular septum in the peristernal long axis. When we look at the peristernal short axis, we can see perimembranous defects like in our example in this region. You can see the membranous or outlet defects here. Then as you get over to the 1 o'clock position adjacent to the pulmonary valve, these are those subarterial or infundibular VSDs, outlet VSDs that we can characterize. Going further down towards the apex, we can look at both the muscular septum as well as the inlet septum. By far the easiest view to look at for the inlet VSDs is the 4-chamber view because they sit right underneath the AV valves back posteriorly, and we can also see muscular defects quite readily. As we angle up into the left ventricular outflow tract view, we can see that perimembranous defect like we did in our example, as well as muscular defects. Well, complications with VSDs do occur, but thankfully they're not that common because we tend to close significant VSDs, significant size VSDs earlier in life. Well, if this does not happen in early life, you may have irreversible pulmonary vascular disease or something called Eisenmenger syndrome. Endocarditis can occur on the VSD. Valves that are in continuity with the VSD, such as the aortic valve and tricuspid valve, can be distorted and have regurgitation. You can have the development of right ventricular outflow obstruction in the form of what's called a double-chambered right ventricle in patients most typically with a membranous VSD, and the long-standing volume overload can cause LV dysfunction as well as arrhythmias in patients with VSDs. What's the surgical indication for these patients? If you're an infant with a large shunt with heart failure and poor growth, despite optical medical management, then those infants are typically repaired within the first year of life, most usually within the first 3 to 6 months of life with a surgical repair. The child or adolescent with a significant VSD that has left heart enlargement, but still has a responsive pulmonary vascular bed with normal pressure and resistance, can undergo VSD closure. Those that have infective endocarditis or have progressive aortic insufficiency due to aortic valve prolapse will also undergo closure of their defect. If you're an adult with a VSD, a class 1 indication for closure of VSD would be a QPQS greater than 2 with associated left atrial, left ventricular enlargement or a history of endocarditis. Class 2A recommendation would be a smaller shunt with a PVR less than 2/3 of systemic vascular resistance, or a QPQS of 1.5 in the presence of LV systolic or diastolic failure. Patients that have severe irreversible pulmonary hypertension should never have their VSD closed. All right, so let's move on to a second case of a 35-year-old with a cardiac murmur and progressive shortness of breath. So this is a subcostal view, looking at here the right atrium, the right ventricle, left atrium, left ventricle. Here's the atrial septum, and in the middle of the atrial septum, we see a large defect, and by color flow, we can see quite a large shunt from the left atrium to the right atrium, so a left to right shunt across this atrial septal defect. From the bicaval or sagittal view, we see the SVC here, the IVC here. Here's the left atrium and right atrium. Here's the atrial septum. Again, we see that large hole or defect in the mid portion of the septum with a large left or right shunt. In the parasternal long axis scan plane, we see the left atrium and left ventricle. We see significant dilatation of the right ventricle up here anteriorly. In the short axis, we see the left ventricle back here posteriorly and a significantly dilated right ventricle. Here we can see another view of the atrial septum where we're perpendicular to it to assess the atrial septum for any defects. And by color flow, again, we can see a left to right shunt at atrial level. The four-chamber view, one needs to be careful because you're not perpendicular to the plane of the atrial septum, but you're parallel, so you can have dropout. However, in this case, we have ample evidence for a large atrial septal defect here, significant dilation of the right atrium and right ventricle, and by color flow, we see a significant shunt from the left atrium to the right atrium down to the right ventricle. So when we think about atrial septal defects, again, we can have a patent foraminal valley, but a true atrial septal defect is most commonly a secundum defect located in the central portion of the atrial septum, like in our example that we just saw. A sinus venosus ASD can be present either superiorly or inferiorly down by the IVC or superiorly by the SVC. And then you can have what's called a primum ASD located down by the atrioventricular valves, which are located here. With a primum ASD, we lose that atrioventricular septum so that the AV valves are located at the same level. So the mitral and tricuspid valves are located at the same level. This is also known as an AV canal type ASD. And finally, a coronary sinus ASD or an unroofed coronary sinus is the least common type of atrial septal defect occurring in less than 1% of patients. So as we look at atrial septal defects in total, they occur about 10% of patients with congenital heart disease. The physiology and the consequences of the ASD really depend on the magnitude of the shunt and the duration in months and years that the patient has had the shunt. And really the flow across the ASD is not primarily dictated by the size of the ASD, but by the ventricular compliance of the right ventricle. So the more compliant the right ventricle, the larger the degree of shunting will be across the atrial septal defect. What's our goal when we look at echocardiography? Well, we want to look at the size, shape, and in particular, look at the various rims of the defect and various imaging planes. We're in an era of interventional device closure, and our interventionalists want to know what are the sizes of the rims, are they all present, will a device sit nicely in the size, shape, and the rims of the ASD. We want to know the degree and direction of shunting, any changes in heart size and function, particularly you have right atrial and right ventricular dilatation in patients with ASDs. And then we can look at things with spectrodoppler, including the left atrial to right atrial gradient. As we talked about, the imaging plane that's essential to viewing ASDs is the subcostal imaging plane, because the beam of the ultrasound is perpendicular to the atrial septum. Apical four-chamber view, again, is the least helpful view because the imaging plane is parallel and you may have false dropout with that imaging plane. So the natural history of ASDs, you may have spontaneous closure if your defect is under 5 millimeters in size. Those patients with defects of 8 millimeters or greater tend to have a lower incidence of spontaneous closure and will go on to need either interventional or surgical closure of their ASD. Outcome with ASDs is typically quite good. Symptoms usually are uncommon in the first few years of life, so we often delay elective closure till 3, 4, 5 years of age. Larger defects may have symptoms such as decreased growth, increased respiratory infections, or dyspnea and fatigue, as well as congestive heart failure, necessitating earlier closure of the defect. In adults that have had unrecognized ASDs, they'll have prominent right heart dilatation, may present with arrhythmias, strokes, heart failure, or similar to ventricular septal defects can present with Eisenmenger syndrome. How do we manage secundum defects? So secundum defects, we opt for elective closure, typically in our children between 2 to 5 years of age, if they're asymptomatic with significant left to right shunts. Certainly surgical closure can be done at any age, but in this era with secundum defects, most centers opt for interventional device closure as the first option. Okay, let's contrast that case with a 20-year-old who presents with Eisenmenger syndrome. So we're looking at her pictures here. We're in the subcostal imaging plane. We have our optimal view of the atrial septum. Really, from a two-dimensional perspective, I really don't see much of a defect here, or even on close-up, we don't see much of an ASD. As we look at the bicaval view, we see the SVC here, the IVC down here. Here's the right atrium, left atrium. Here's the atrial septum, and we see a defect located right here in the superior portion, just adjacent to the superior vena cava where the ASD occurs. So this is a superior sinus venosus ASD, and as we look at the color flow, we can see bidirectional shunting, most notably right to left with all this blue color flow in this patient that has Eisenmenger syndrome. Parasternal long axis imaging plane, we see significant dilatation and poor function of the right heart. We see compression of the left ventricle. And in the short axis, again, we see compression of that left ventricle, flattening or even reversal of the septal configuration consistent with suprasystemic RV pressure with severe dilatation, severe hypertrophy, and significant ventricular dysfunction of the right ventricle. As we tip up into the tricuspid inflow view, we can see significant tricuspid regurgitation in this patient. From the pulmonary outflow view, we see dilatation of the pulmonary artery and the pulmonary annulus here and significant pulmonary regurgitation. Finally, looking at the four-chamber view, we see the right atrium with a line present within the right atrium, significantly dilated right atrium, the right ventricle significantly dilated and hypertrophied with decreased function, and we see that compressed left ventricle as well. We can look at the Doppler velocities from the tricuspid and pulmonary regurgitant signals and predict the RV systolic pressure being suprasystemic at 135 to over 60 millimeters of mercury. So sinus venosus ASDs are really not an absence of the atrial septum, but rather a missing portion or an unroofed portion of the pulmonary vein as it connects to the left atrium, creating an intra-atrial communication from the left atrium to the right atrium. It can be located adjacent to either the SVC or IVC, more commonly the SVC. It's associated with anomalous pulmonary venous return, and in this diagram you can see the right pulmonary veins connecting to the superior vena cava, which is most commonly the case, and it's usually the right upper and the right middle pulmonary veins. And these patients are surgically corrected with what's called a Worden procedure, where the anomalous pulmonary veins are baffled through the defect back to the left atrium, and the SVC is dissected, transected, and reattached to the right atrium. This cannot be corrected by an interventional procedure. So here's a nice example of a superior sinus venosus defect, similar to our patient, adjacent to the SVC. Here's an inferior sinus venosus defect adjacent to the IVC. Well, as we said, this patient has Eisenmenger physiology, which is most common with ventricular septal defects, where you go from having a left to right shunt to having a right to left shunt with suprasystemic RV pressure. But we do see that in patients with atrial septal defects as well. The Eisenmenger syndrome was first described back in the late 1950s, and it really occurs with left to right shunts that cause increased pulmonary blood flow with shear stress and circumferential stretch on the pulmonary vessels, leading to endothelial dysfunction, vascular remodeling, smooth muscle cell proliferation, increase in extracellular matrix, intravascular thrombosis. Then you get your increase in pulmonary vascular resistance, reversal of your shunt, and then have cyanosis or Eisenmenger. And you can see from this study, most commonly in these two large studies of Eisenmenger syndrome, VSDs were the most common, but we see it with AV septal defects as well as atrial defects and patent ductus arteriosus, as well as some other congenital heart lesions, but by far the most common VSDs and ASDs, as well as PDAs. All right, so moving on. This is an 18-month-old female with Down syndrome or trisomy 21 and a prenatal diagnosis of congenital heart disease. So again, we're starting in the subcostal imaging plane. We see the right atrium here, the left atrium here. Here's the atrial septum. We see a defect here, which we now know is a primum atrial septal defect. We see the atrioventricular valves, the tricuspid valve, and the mitral valve are at the same level because this is absence of the atrioventricular septum that creates this defect. In concert with this, we often see an abnormality of the mitral valve, and we do in this case. This is the left ventricle. Here are the two papillary muscles. We can see the posterior and anterior leaflets, and the anterior leaflet in the middle here has what's called a cleft or a gap in that, and the gap is called a cleft in the mitral valve, and it almost always is in the anterior leaflet, very, very rarely in the posterior leaflet. In the four-chamber view, we can see a nice image of the inferiorly located primum atrial septal defect, the right heart dilatation of the right atrium and right ventricles. We see the common level of insertion of the tricuspid and mitral valves, and no evidence of a shunt at ventricular level. Here we can see a left or right shunt across the primum atrial septal defect. See a little bit of tricuspid regurgitation, and we see regurgitation from that mitral valve cleft into the left atrium. So this leads us into a conversation of atrioventricular canal defects. Those are defects which have a primum atrial septal defect and can also have an inlet ventricular septal defect. Here's what a cleft in the mitral valve looks like. Here's the anterior leaflet that we see by echo. It has a cleft. And as we think about atrioventricular canal defects, this really accounts for about 3 to 5% of congenital heart disease. Complete canal defects are more common than the partial ones. The male-female incidence of these are equal. There are some defects which are more male predominated, some which are more female predominated, but in AV canals, they're equally associated. One of the most common associations is with Down syndrome. In patients with Down syndrome, 40% will have congenital heart disease, and of those, 40 to 50% will have an AV canal defect. Patients with a very complex atrial isomerism or heterotaxy, either right atrial or left atrial isomerism, will also very commonly have an AV canal defect. The classification of these is really a complete defect, a partial defect, and a transitional defect. The complete defect is much more common. It has a primum ASD, a single common AV valve, and an inlet VSD. The partial defect, which we just saw, has a primum ASD, no ventricular septal defect, and has two separate atrioventricular valves. A transitional canal occurs about 10% of the time, has a primum ASD, and has a very limited or small ventricular septal defect, which may or may not be completely occluded by chordae from the atrioventricular valves. One of the other hallmarks of AV canal defects is a deficiency in the inlet portion of the ventricle to the outlet portion. That's because we've taken away that atrioventricular septum, and so that the inflow is shortened and the outflow is lengthened. And that creates what we call a gooseneck malformation of the left ventricular outflow tract, which may lead to left ventricular outflow tract obstruction in about 10% of patients. Those with partial canals have LVOT obstruction much more commonly than those with a complete canal defect. And in these AV canal defects, the left AV valve is not really oriented towards the apex, it's more oriented towards the ventricular septum. So this is what I talk about when we talk about a gooseneck of the LVOT. Here's an echo showing a nice gooseneck in the subcostal view going out the LVOT to the aorta. Here it is by angiography, and here it is outside our window here in Minnesota in the summer. So always remember, a gooseneck occurs with the left ventricular outflow tract in patients with AV canal. Contrast that with, this is a 2-day-old with the prenatal diagnosis of congenital heart disease. Again, the subcostal scan plane is where we start. We see a primum ASD. We see a common AV valve here. We also see a secundum ASD. And when we rotate to the sagittal view of the ventricles, we can see a beautiful view of the en face view of a common AV valve that's situated both over the right ventricle and left ventricle. The right ventricle size here, the left ventricle size here are both about the same size, so we would call this a balanced atrioventricular canal defect. We can look closely at this again and see the anterior and posterior bridging leaflets, as well as looking at the size and function of the ventricular chambers and assuring ourselves that there's no right ventricular outflow tract obstruction, as tetralogy of Fallot can occur in the setting of a complete AV canal defect, most commonly with trisomy 21 or Down syndrome. So a nice view to exclude right ventricular outflow tract obstruction. And we also want to look for the presence of multiple jets or a single jet of AV valve regurgitation. Here's that long peristernal long axis view that we've seen with that elongation or the gooseneck of the left ventricular outflow tract. And notice we don't see the mitral valve leaflets in this view, and that's because that leftward component of the common AV valve is really oriented in this direction towards the ventricular septum, not in this direction towards the apex of the left ventricle. And then here's an apical view showing us very nicely the primum ASD, the inlet VSD, the common AV valve, and our right and left ventricular chambers. Here we can see significant regurgitation from the right side of the common valve and multiple little smaller jets from the left side of the common AV valve. So when we look at a complete canal, we have a large VSD and large ASD and a common AV valve. These patients typically will have a large left or right shunt in the first year of life and go into congestive heart failure. Patients may continue to have elevation of their pulmonary pressures, particularly babies and young children with Down syndrome. So we need to follow these patients closely. We operate generally within the first 3 to 6 months of age to prevent the development of permanent pulmonary hypertension. Both AV valve regurgitation as well as LVOT obstruction can develop later on. So these patients need to be followed lifelong. And again, we repair them early to avoid pulmonary hypertension. So as we look at AV canals, we can look at the complete canal here and the partial canal here. And we've talked about in partial canals, the ASD is here. There's no ventricular component, and we have 2 AV valves. The transitional canal, where we have a very small VSD, a large primum ASD, but 2 separate AV valve components. The complete canal, where you have a common AV valve and a primum ASD and a large inlet VSD. And then there's something called an intermediate canal, where you can have both a large VSD and a large ASD, very similar to a complete canal, but you have 2 separate AV valves. And so that's sort of a intermediate between a complete canal and a partial canal. So we call that an intermediate canal, and those are much less common. So with that, I'm going to end this first lecture detailing the segmental approach to congenital heart disease, as well as some examples of some simple congenital lesions. And as I said, in our next lecture, we'll talk about some more complex congenital heart disease. Well, thank you very much for your attention.